Good morning. On behalf of the Inter-American Development Bank, we welcome you to the event, Norway's Approach to Combating the COVID-19 Pandemic. A conversation between IDB President Luis Alberto Moreno and Dr. Camilla Stoltenberg, Director of the Norwegian Institute of Public Health. The event will be in English with interpretation into Spanish. Para escuchar el evento en español, haga clic en el icono del mundo que encontrará en la parte baja de su pantalla y seleccione el idioma. Please send your questions to paulc@iadb.org. President Moreno, please go ahead.
Well, good morning, everybody, and good afternoon to Dr. Camilla Stoltenberg. She's the Director General of the Norwegian Institute of Public Health, which is one of the highest reputed institutes on health and diseases around the world. And equally to welcome you, Norway being a very generous shareholder of the IDB, one of our principal European donors, and a country that is always done so much for the rest of the world. Today, as we know, there is the Gavi Alliance, where there's a pledging conference and where Norway is always ahead trying to help the rest of the world. So I'm really privileged to have with us Dr. Camilla Stoltenberg, and also to begin this conversation, perhaps the best way, Camilla, is that you give us a context of how has Norway faced this crisis, some of the challenges that you faced initially, and of course the very impressive results that you've had so far, which you know, in this world where everybody is trying to test ideas, you've been able to be very, very successful, and of course it's a great source of inspiration and learning for the rest of the world. So over to you, Dr. Stoltenberg.
Thank you so much for inviting me to this conversation. I'm really pleased and flattered that I am invited to do so, and representing Norway is also a pleasure in this context. Although it is easy for a fairly rich country with a long tradition of democracy and trust in society to meet the challenges that the COVID-19 epidemic represents compared to many other countries that are not in an equally easy position. So I wanted to say a few words about myself and the Institute first, and about Norway before we move on to the COVID-19 response. I'm a medical doctor, and I've been director of the Institute of Public Health in Norway since 2012. So for 8 years, we have been developing this institute, and it is at the moment a very broad institute with responsibility not only for infectious disease prevention and emergency preparedness, but also for non-communicable diseases, for mental health, for doing rapid systematic reviews of science to provide knowledge to both the public health system and to the healthcare system in general, so the whole health system. And we also participate in many international efforts to strengthen public health across the world, not only because we will show our solidarity, but also because we think it is of our own interest. And that is not a characteristic only of infectious diseases, but also in general. We believe that international collaboration is incredibly important in response to all the health challenges of all kinds that the world is facing. And we see that very clearly nowadays. So also Norway is a relatively small country with approximately 5.3 to 5.4 million people. And it is a strong and wealthy welfare state where healthcare is almost free. There is some payment, but limited, and it's available for all. The public health system covers everyone. So we are in a good position also because the educational level is high, and because the trust in the political system and the system in general is very high. So with that background, we at the Institute were aware of, as many other institutes institutes across the world at an early stage, even in January, that the outbreak that we saw in China could represent a pandemic, and we quite rapidly thought that this would probably develop into a pandemic. So we prepared ourselves for the situation where it would reach Norway, and it did so. We had our first registered case in the end of February, on February 26th. And then within a few days, actually, within the week that followed, we had many hundreds of cases. And that was because Norwegians had gone on winter vacation skiing in the Alps in Central Europe, to Italy and to Austria in particular, but also to other countries. It turned out also to Spain, and they returned to Norway, and many had contracted COVID-19. We know now that we weren't able to test and diagnose all of those who returned at that moment, and soon thereafter we realized that we did have silent spread of the disease in society. We were not able to trace all cases back to those people that we had identified that had imported COVID-19 or the virus to Norway. So it all developed very rapidly from the 26th of February until the 12th of March, which is the date when the Norwegian government decided to implement a whole package of restriction measures. And the Prime Minister declared, with the Minister of Health, supported by both the Director of Health in Norway and me as the Director of Public Health, that we would implement all these different restriction measures. What happened at that moment was that the whole population was with the government, and the government was incredibly good, I think, in communicating the importance of taking this seriously. So the engagement from individuals, from the whole population, from groups in the population, from NGOs and all governmental and public institutions at community, at the local community level up to the national level, was immense. So we think now that that individual and collective engagement was incredibly important in taking the advice and the regulations seriously and actually getting an effect on decreasing or actually almost stopping the spread of the virus within a very short time. We did continue to have an increase in cases and registered people registered who had tested positive until about the 1st of April, but then it started to slow down and eventually end up at a very low level where we are now, where we have altogether had 237 people who have died, but no influence so far on total mortality. And we have had more than 250,000 people that have tested and about 8,500 that have tested positive since the 26th of February. And the number of people that are receiving intensive care is now very low, and the number of people that are being hospitalized is very low. Since the restriction measures were implemented from 12th of March, so they weren't all implemented at once, and the days after that, it took only a few weeks or about a month before it was decided to lift some or ease some, adjust some of the measures. So that started around the 20th of April, and we're still in that phase where a range of measures are being lifted. First, kindergartens and schools opened slowly again with hygiene routines, so that they're more cumbersome to run than they usually are, but they have in principle opened all of them. And the big discussion now is whether the borders, particularly to the other Nordic countries, should open also. But at the moment, what we see is that there is a great satisfaction and relief because there are so few cases, and we have got the time to prepare ourselves in case there will be new waves of disease but also to be able to detect new spread at a much lower, earlier stage and stop it with simpler, less costly measures, both in economic terms, but also in terms of restricting individual freedom. I think that's a background.
That's an excellent background, doctor. And you know, everybody always looks at Nordic countries with envy, in the sense that you've always been able to have this a welfare state of kinds with great public systems. And you mentioned small countries, and it's fascinating. If you look at Latin America, the countries that have done the best are actually some of the smaller countries, countries like Uruguay, like Costa Rica, like El Salvador, are countries that have done tremendously well. And of course, Singapore or Taiwan, which equally did very well. But you have a neighbor which took an entirely different strategy from you, which was the case of Sweden. How did your population, even though you have all of this trust, weren't people kind of questioning, or how did you manage those differences? Because I'm sure you were, there were a lot of questions, I'm sure, in Norwegian society as to the merits of the lockdowns that you were doing vis-a-vis what Sweden was doing.
Well, the differences are really striking at this stage of the pandemic, with so many more deaths in Sweden and still a considerable spread of the disease. But I think we should not be arrogant in this stage, because the way we think in Sweden and in Norway or in the other Nordic countries is not very different. There are some differences that we know today, which are that in Sweden, the public health authorities have been running the response without the kind of involvement from politicians that we have had. But on the other hand, some countries where politicians have been in charge have not been doing well. So I think it's all about a whole set of ways of responding that make up the difference, but it could also be factors that we haven't really thought about. For example, how many people actually came to the country with the virus originally? How many were they those that we did not test and were not able to detect before it had spread quite a lot? So I think there will be years before we are able to know what was really the best strategy, because we are not safe yet. I'm really relieved that we have had the approach, and I do support the approach that we've had in Norway, but I think it's both an experiment in Norway and in all other countries and in Sweden as well. And it will be very hard to find out what exactly went wrong and what was right.
Doctor, tell us a little bit about the testing, because you have been very targeted in the way you do the COVID-19 testing, and you didn't do it for, you didn't do it in a comprehensive way, but rather in a very targeted way. How did you manage that, and what was the thinking behind it, and was this something that you had thought through before as you thought about pandemics and thought about these challenges, which I'm sure you were doing at the Institute before?
Well, ideally, in such a situation, we would have and I think that will be one of the things that we will evaluate carefully. Ideally, we would have wanted to be able to scale up testing capacity much more rapidly than we were. We did scale it up considerably at an early stage, and we tested among those countries that tested most people in the world for many weeks during the most intense period of spread in Norway. But we were not able to have a capacity that could encompass both targeted testing with a low threshold so that everyone with symptoms could be tested. And we were not able to have the capacity to do population-based testing at that stage. Now we're able to do both. So we do targeted testing, but with a very low threshold. We're actually at the moment encouraging people with any kind of symptoms that could resemble COVID-19 to get tested. And there will be a campaign now, so everyone will be tested, so that they will realize at this stage that if there's any indication, you can get tested. So that's the targeted part. And in parallel, we are now doing population-based testing, and we're doing it based on our population-based studies. We have several very large population-based studies that are ongoing. So for example, when we test for whether people have gone through the infection, whether they have antibodies, then we can also look at whether those who have developed antibodies have any genetic disposition for doing so, whether there are genetic differences in the response, etc. So that's a very rich source for information that will be important both in Norway, but possibly also for other countries. And we also test directed, population-based, but directed towards particularly vulnerable groups. For example, people living in care homes or some of the immigrant groups in Norway, etc. So we wish we had been able to do that at a much earlier stage. It's good that we're doing it now, but it would have been better if we had been able to do it already in March, which we were not. So I think that's one thing that we will learn from this, that scaling up testing at a much earlier stage could have been important.
Doctor, you know, many countries are doing, of course, every country had a shortage of testing and had to ramp up, get the laboratories, the robotic laboratories, such that you could process more things. And of course, we have the PCR test, we have the serological test to determine, especially on those, if people are asymptomatic or not. There is a lot of talk now that you have to do different kinds of tests along the way. Have you been, and I saw it here in Mount Sinai Hospital, beginning to think about gradually changing the types of tests to be able to be far more effective. Are you looking at something like this?
Yes, we are. If I understood you rightly, we are now looking at combining, when we test for the virus, we should also test for antibodies. But we're still discussing what kind of serological tests that should be used routinely. And there's not the final agreement on that, but serological testing is now ongoing in several different contexts, both population-based, as I said, but also on patients.
Talk to us a little bit about, you did some diagnostics that you were doing through video and basically at a distance. How did that work, and did people go to a specific center where you had doctors to be able to process and look at the diagnostic, and then based on that, then take people into the testing system?
No, you mean diagnostics. I'm not sure I understood your question correctly. We've had, but I'll try to respond to it. We've had we've had centers where people can go to get themselves tested. So they've been, for example, in tents outside of hospitals. So the testing facilities have been organized so that they're separate from the healthcare facilities, so that you do not spread the virus. So that's one thing. But
I'm referring more to the distant diagnosis.
Yes, but that hasn't been used so much in consultation with people who have possibly have contracted COVID-19, but for all patients, because people were encouraged to stay home, not to go to the healthcare facilities. For some specialties, actually, that has increased the number of patients that they've been able to take care of. So I heard earlier today that in Norway, actually, during this phase, many more patients with neurological disorders have been able to be in touch with their specialist. So that's perhaps improved the care that they receive. That's completely independent of COVID-19, but the use of the digital consultation has increased enormously. For COVID-19 patients, that's just been a way of discussing whether you should come to get tested or not. So that's been used also, but I think there's been a lot of variation between different municipalities depending on their attitudes and their opportunities when it comes to contact with patients, how it's been practiced. And I haven't seen that that's been summarized in any way. But it's a very digital society, so we do use digital contact also with the healthcare system regularly. Or we did use it regularly before this started, but it's increased enormously now.
Well, I have a lot of questions coming from the audience, and I'll start with one. It's with the first one. Is can you describe the medical protocol you have been using for people that do get sick? What medications have you found to be effective?
Well, that's actually not my specialty. I don't know if Frode Forland can respond to that, but I think perhaps that we should refer that to some other person who's involved directly in that part of taking care of patients. Frode, do you want to respond to that?
It's a too clinical question for us to, yeah. I think we are trying to avoid overuse of antibiotics. I think that's the only thing I can say. We've seen from other studies and other countries that there has been a massive use of antibiotics for people having a viral infection. And we had a discussion today in the antibiotic committee in Norway, where we don't get any reports of such an excess use of antibiotics. And we're part of also some of these trials led by WHO to test different regimes in a controlled manner, both the antivirals for HIV, the anti-malaria drugs, and also the HIV drugs. Yeah.
And I can add one more thing, and that is that we have, from before this COVID-19 outbreak, very clear protocols when it comes to who's being hospitalized and who's being referred to intensive care units. And that means that, for example, most people who live in care homes, they will not be referred to intensive care and they will not even be hospitalized. So I think that affects the, for example, the number of people who survive intensive care, because those who will not benefit from it will not receive it. It has, again, nothing to do with the COVID-19 disease in itself. It's a general rule that we follow that we think takes care of patients in the best way.
Another question is, did you notice any integrity issues related to the government response to the pandemic, such as attempts to overprice health supplies or sell medical items that were not up to standards?
Well, we have, we're not selling medical items from Norway, so we're not producers, but we have imported and bought a lot, and some of it hasn't been up to standards, definitely. So that's been a huge problem initially. Now it's much better, because those who do purchase this equipment, they have become experts, I think, in doing so. So we now have storage, which is fine, which is considered to be sufficient, and we also think that we have access to supplies. But it's been a big challenge, as in all countries initially.
Are you worried of a contagion increase coming from Sweden, and how would you mitigate this?
Well, we are worried about that, and we're discussing it these days. So we do not know what the actual conclusion will be, and it's definitely not only a question of a medical or a health issue. It's also a political issue. Not only the question about the borders to Sweden and how we will deal with that, but also to other countries. So there's a big discussion going on in Europe at the moment on these issues, and I think that there are many different interests and legitimate interests that are weighing into it. So the government will eventually decide on that next week.
Another question is, for your testing, do you only use public laboratories or do you use private laboratories as well?
But mainly use public laboratories, but for serological testing, there are now many private laboratories that are doing the testing also. And some private laboratories do testing sort of commissioned by the public healthcare system, so paid by the public healthcare system.
Here's
so
another question.
The distinction there isn't entirely clear.
Okay. In Buenos Aires, which is the largest city in Argentina, they're coming up on 80 days of isolation. The curve is not being flattened. And what would be your recommendation? Is lockdown or isolation the only solution?
is lockdown and isolation. Well, it's very hard for us to give specific advice on the situation in Buenos Aires, I think. I don't know enough about it, so I would be careful in doing so. But I think that it's important for all countries to emphasize the importance of the simple measures: social distancing, hygiene, hand washing, and also capacity for testing, for isolation of patients, those who have tested positive, and those with clear symptoms, and for contact tracing if at all possible. And also for developing good surveillance systems and for having strong institutions that are running and are responsible for the response at a national or a regional level. But I'm not in a position to advise on the particular situation of Buenos Aires. And we see that, I mean, England is in the same situation, particularly London and the big cities. I don't know if you want to add to that, Frode.
I'll unmute again here. Just shortly, I think what you're saying is it's perfectly correct. There might be different situation in different countries, and that measures must be adjusted to the setting and to the standards of living in different countries. And we've seen also, not from South America, but from Africa, where people have very poor living conditions, that the measures that they are trying to impose, which have been like European inspired, have probably also caused more harm to the society and to poor people who don't have an opportunity to go to their work, not having an opportunity to earn their living for the day. So I think it has to be adjusted day by day. And in Norway, either there wasn't a full lockdown. It was actually a partly lockdown. Shops were always open. People were allowed to go out the whole time through this period. And also restaurants were open as long as you could keep distance. So I think it's also finding the right level. But what I think was very successful in Norway was that it happened very fast, that all the measures came at the same time. And that made also this impact on the whole population. That made everybody take this very seriously. This is now, and we have to adjust. And the whole society adjusted in a very, I would say, surprisingly rapid manner to political decisions made over the day. Thank you.
Thank you, Dr. Forlan. One of the, Dr. Stoltenberg, one of the areas that you alluded to was the whole question of dealing with vulnerable societies. And I'd be fascinated to listen up to you about how you dealt with the most vulnerable groups, which clearly everywhere around the world are some of the groups that are being the most affected. And especially indigenous populations like the Sami people, for instance. Have they been particularly more affected than the rest of the Norwegians?
Well, regarding the Sami population, we don't have any way to distinguish those from the rest of the population in Norway, unless they want to do it themselves. But there's no reason to think that they've been affected in other ways than the rest of the population. So there's quite a considerable number of people with Sami that are part of the Sami population who live in Oslo, where relatively many have had the disease, and there's also a relatively large group living in northern Norway, where very few have had it. So we don't think that they've been affected in other ways than the rest of the population. But those who have, for at least for a while, were some people with background from Somalia, and most of them live in Oslo, and that was they were contacted, and the communication between authorities in Oslo, supported by our institute and that group, led to a very rapid decline in the spread of the disease. So that was dealt with in a very good way once it was identified as an issue.
Another question here, which is a fascinating idea that clearly is going to be very important for countries, for instance, in the Caribbean of Latin America, which are so highly dependent on tourism, is this notion of travel bubbles or travel corridors. Is that gaining traction? And this, of course, Norway just announced the creation of one such travel bubble as you connect to Denmark. Is this the best way to restart international travel in the coming months?
Well, I think nobody knows what's the best way forward on these issues. And you're really touching upon an issue that we have not resolved in any way, and we see it as a very challenging issue. Tourism and travel is very important for Norway also, and we see, as I said initially, that there are so many different interests here that are all legitimate, but very hard to weigh against each other. So I know what the situation was on our own discussions about this, but I do not know yet what the conclusion will be. And as I said, we will know more on Thursday, but I think that we will have a dynamic response to these issues. And although there's a bubble now with Denmark, and there may be a bubble with the Nordic countries, I don't think that's sustainable over time. And we will have to look at how to deal with this continuously for the months or even years to come.
Another question is coming from the audience is, could you describe the specific steps that Norway schools are taking to prevent infection? For example, are you limiting a number of certain activities or the number of children that can be in a classroom at the same time? It's a fascinating and incredibly important question.
It's a very important question, and I can respond to that on a more general level, but I think in fact it does address something that we should think about, and that is to translate our manuals for how to run schools and kindergartens in the different phases. And there's just been a new system that's been introduced, which is a traffic light system, where we say that if the traffic light is red, then you have to have these measures or these routines, and if it's yellow, you can have these that are more liberal, and if it's green, of course, that's normal, or as it used to be. But we're not where it used to be. We're now at the yellow level, which means that we have lifted even those first routines that were implemented. But the details around those, they are that for the youngest children, we established cohorts. So those shouldn't mix at that time. Now they're allowed to mix. So it's a very complex issue to respond to, or question to respond to in detail. But I'll encourage our institute to translate some of those manuals that have been developed, because they might be useful for other countries. But it's been a success so far. We haven't seen spread connected to schools and kindergartens. We've seen single cases of people, either pupils or families or people working in the schools, that have contracted the disease or have been tested positive, but no outbreaks.
You know, this is, we would love to get a copy of those manuals, because clearly, like you say, we're all learning, and one of the areas that has one of the most important consequences, of course, is education, and especially children, which are being severely affected. And of course, we're all riding on the younger generations as we would deploy these huge amounts of fiscal stimulus to support and jobs and those jobs to remain. So this is a very important aspect going forward. Another question is, are you in Norway tracing the close contacts of symptomatic people, irrespective of those who are asymptomatic among the contacts? And how do you deal with the false negative rate among asymptomatic contacts?
Well, we are tracing contacts regardless of whether they're symptomatic or not. We have had a system of quarantine for all close contacts, meaning being closer than 2 meters for more than 15 minutes, regardless of whether they have symptoms or not. And in addition, quarantine for not only close contacts, but people who have arrived in the country, regardless of where they come from. Now, it's been reduced from 14 days to 10 days. And also, now will probably be lifted further. So the false negative, was it the false negatives you were concerned about?
Yeah, the false negative, yes.
Yeah.
The false
Among
negative
the
rates
close
amongst
contacts.
asymptomatic cases.
Yeah. Those have not been a problem so far because they've all been in quarantine.
Can I add to this shortly?
Yes.
To say that I think we have a strength with the Norwegian health system, that we still have many municipalities, like 350, and in each and every municipality there is a this infection disease responsible medical doctor, and he's also responsible, or she's responsible also for infectious disease control at the homes for the elderly people, and they are the ones responsible for all the contact tracing. So this is really done at the local level. It's nothing done by our institute at the national level. We are just supporting the ways of doing this for all the municipalities. So for the time being, we have an hope that we can actually trace each and every one and isolate them and test them, and also cover up minor small outbreaks in classrooms or in workplaces or whatever that might come in the year to come. Thank you.
That's great. Thank you, Dr. Forla. Another question is, have you been looking into the possibility of a health passport as a more permanent measure for the future?
Not seriously. We have discussed it, but as long as we're so uncertain about the serological testing, we haven't considered that to be a solution so far. But we have a definition of when people are sort of free of the disease. So when they're out of quarantine or 14 days after they've had symptoms or been hospitalized, they're considered healthy. So we've also said that for the 6 months following that, they can be considered to be immunized, but we don't know whether that's a valid way of doing it. There's no reason to think that it's not, but there's not strong evidence supporting that it should be exactly 6 months or that all of them are actually immune, because we know too little about immunity. So that's our passport, but it's not an actual passport. Would you add to that or correct some of what I said, Frode? No, it was probably correct then, because all these things are quite dynamic. They change.
No, I think it's perfectly right what you've said. Yeah.
Thank you. Another question is the anti-vaccination movement active in Norway? And if so, how do you plan to encourage them to take the COVID vaccine once it becomes available?
Well, there's a very strong support for vaccination in Norway, and we have very high coverage in the childhood vaccination program, and also increasingly high in other vaccination programs. And the anti-vaccination movement has been quite silent lately compared to what they were 10 years ago, and for some years after the last pandemic, the influenza pandemic in 2009, 2010. But of course, we do not know whether there will be new waves of anti-vaccination movements. We're more interested, in fact, in those who are skeptics, which is much easier to understand also, because particularly when vaccines are developed very fast, as they may be now, and also in a situation where we don't really know how well they will work, and whether they will work for everyone or just for some, and whether some groups are more susceptible to adverse events as part of vaccination. So I think that's important to deal with in a very open and serious way. And that's the general issue that's important for all countries. So anti-vaccination movement issues haven't been that important, at least not so far, but we should keep it in mind. And in general, at an international level, it is of course very important.
Speaking of vaccines, as you know, today Gavi is having its third pledging conference to financing vaccines for measles and diphtheria, and how, and of course for COVID. What role will Norway play in all of this, and its efforts to develop the new vaccines and drugs?
Norway has been very active in funding both Gavi, but also CEPI, the Coalition of Epidemic Preparedness Innovations, which is funding development of vaccines, particularly for low-income country, not specific, but almost specific diseases, and is now heavily involved in developing a COVID-19 vaccine. So we will continue to be so, according to our political authorities, which I think is very good. And we are, as an institute, supporting that work, but we're not responsible for it. We're not making the decisions on it, but we're certainly encouraging it and following up with knowledge to support it, and also to look at how Norway can contribute both to development of vaccines and production of vaccines internationally, and also, of course, for supply for the Norwegian population.
And as you know, one of the big questions, of course, for Latin America is the race to the access to the vaccine. I mean, the minute it's developed, how is it distributed? And we know not every country has the capacity that a China or an India or Brazil have in production of vaccines. How do you see that balance and that distribution, which I think is a huge challenge for the world and a very hard task to come to terms with?
Very hard, and with lots of difficulties on both sides. And we see that several countries are sort of unilaterally trying to secure their own interests. But the good thing, or the thing that provides some hope for all of us, is that no country, not even the strongest and richest one, will be able to know exactly how to secure their own interests. So in order to do so, they must fund, or we must fund, many different initiatives to develop vaccines and to produce vaccines. And that means that if we manage that in a sufficiently wise way, we should be able to get some access also for low-income countries, or for groups, population groups that will not get an easy access unless there is some international collaboration and solidarity as a basis for this. But it's difficult and with lots of problems along the way. But the situation is that now everyone needs this vaccine or these vaccines, not only the poor countries.
Right.
So investment will be enormous, and the chances of succeeding is much higher than when you're doing this only or mainly for solidarity reasons.
There's another question here. In Latin America, it's not uncommon that 3 generations live under the same roof. Do you have an idea of the infectious potential among asymptomatic children? And could asymptomatic children communicate the virus to their grandparents, for instance?
Well, that's something that we don't know enough about. They probably can, but we do not think that asymptomatic children are big spreaders of the disease. But when they live very close together, it is, of course, a risk. But that's definitely something that needs to be investigated in more proper and larger studies. It's a very important issue.
You know, we're coming to the end of our time that we had set up for this, and we don't want to abuse of it. But just one last question is, as you sit back, and I'm sure you had since this started late in February, when you saw the first case in Norway, of all the intensity and all the learning that you've accomplished so far, what makes you optimistic of what you as a country have learned, and more importantly, the things that we can translate to humanity as a whole?
Well, what makes me optimistic is to see people's personal engagement and how important that is. That is key. So you have to be open when you work for the governments, as we do, be open and be open about uncertainty, and communicate closely with people, and then they will be with you, and they will also come up with new ideas, and they will follow up and implement the measures in a way that is effective. That's at least the experience that we've had so far. I'm also optimistic when it comes to development of vaccines, although there are so many difficulties when it comes to access. But if there is sufficient interest in that, we should work on the access issue, but we will get a vaccine, I do think. I'm not 100% certain, and we should plan for a situation where we do not get it fast, but we've never been in a position to get it as fast as we may get it now. So I'll point to those two things. What worries me more is international collaboration, because I don't think that this can be met or dealt with in a good way unless international collaboration is emphasized and strengthened further. And I think it's incredibly important to look up, not be so concerned about the issues that are local or national, but that you forget how important that is, not only to mitigate the situation, to handle the response, but also to be able to not be in such a bad position in the future if we get new pandemics or if there are new waves coming in this pandemic. And now that we see it's increasing in so many countries that are poor and with huge populations, now is the time to strengthen international collaboration and to think more about that, or equally much about that as we do about the national response.
You know, I really want to thank you, Dr. Stoltenberg, and it's just fascinating to listen to you, because for all of us who watch your country and northern countries in general, is the humbleness which you approach this, the capacity that you have had to construct what we like to call civic capital, none other than thinking that you have 5.2 or 5.3 million Norwegians all fighting at the same time against COVID. And I think it is that sense of trust and that sense of social cohesion that despite all the differences, you've been able to come together and learn by doing, but doing it in a way that is truly an example to the world. And we really, really thank you for this opportunity. It's really something that we all have to learn a lot from. And certainly we're gonna have COVID for some time, as you know well, and you know, this is a bit of a crystal ball, but clearly we're gonna be at this for some time. And so all the lessons from your country are something that we will definitely follow closely. So thank you again very much for your time. And to the doctor, your colleague right next to you, thank you again.
Thank you so much for inviting us, and we will follow up, and we look forward to collaborating with your country and through international organizations as well.
Great. Thank you so very much. Bye-bye.
Bye.